Okay, thank you, Dr. Ajahn Charlie, and good morning, all panelists. Let's start the first case of the case discussion. My name is Chavarat jarungvittayakon from Ramatipadi Hospital. In my case, is Thai male, 61 years old. The chief complaint is left hip pain for 7 weeks. The present illness, the 7 weeks prior to admission, he fell from motorcycle. His left hip crashed to the floor. He was pain, swelling, and couldn't move his left hip. And he went to the hospital and admit for close reduction for left hip under general anesthesia, and performed the skin traction at his left leg about 10 days, and the clinical was improved and discharged from the province hospital. 5 weeks ago, his left hip was pain again, and he went to Ramatipadi Hospital. No underlying disease and history of drug and food allergy. For the physical examination, the affected part, the left hip part, no swelling, no ecchymosis, and tender at left hip and limit range of motion due to pain, and distal neurovascular were closely intact. And for the investigation in my hospital, and this film for the both hip AP for this case.
Okay, so by this essay, I would like to ask all the panel what is your impression or what happening with this patient with 7 week for all left hip.
Left hip. And this is for the two devil.
Okay. I will start with Dr. Kasisin, please.
Yes, sir. This case is a post-trauma.
Post-trauma.
7 weeks, right?
7 weeks ago, yes.
Okay, and he still has pain.
Pain
on the left hip.
In left hip.
I think it's maybe because of the fracture of the head of the femur. Then maybe has the avascular necrosis.
Initially, no, don't have the femoral head fracture.
Initially, do you have initially fem?
I have the CT scan, only CT scan, because the pain film not sent from the province hospital. Okay, I will show the CT scan after the close reduction under anesthesia. This for the axial view, and the next video is the sagittal view.
Okay, Dr. Kasisin, please.
So the hip is dislocated and then reduced.
Was reduced at the province hospital, yes.
I see. So I think it's maybe from the necrosis of the femoral head.
Okay. Any other list?
In this case, I think the traumatic hip, it's only 7 weeks, and I think it's the diagnosis should be the fracture dislocation of the left hip, and the fracture may present at the femoral head and the posterior wall of the acetabulum. That the CT scan show the fracture of the posterior wall of the acetabulum.
So anybody disagree with the diagnosis or have something else to discuss?
For I myself, if we say about the 7 weeks after the fracture dislocation in this case, and I think the proper management in the initial is try to cause reduction. The question, what is the indication for the province hospital to refer for your, because they need fixation or they need to do anything by the reason of the refer?
because he have the left hip pain again 2 weeks.
Left hip pain again 2
Yeah.
weeks. Okay. Actually, because I think this is just a new post-traumatic, and I would like to ask the symptom like the dislocation or unstable after reduction in this case.
I think they just come to the hospital, so they don't have a lot of information about the patient. So it's just 2 weeks, and the patient come to the hospital and said that he has left hip pain that is not getting better. So what is your diagnosis and what do you think about this case?
Okay, I myself in the case like this, I have 2 questions because first, if the initial diagnosis by the X-ray is just fracture and dislocation, and this is with a big piece of posterior wall, initially we try to fix it in the initial. That's why I have concern that why 7 weeks they not plan for fixation. Another question about the pain. The pain may come from many causes, such as the insufficient or neglected fracture neck of the femur, or arthritis or incarcerate of the osteochondral fragment in the joint, and the recurrent instability after reduction. That's why I think to further management, the first one, we need to diagnose the cause of pain first. Maybe this is the 7 week. If we need, maybe do the MRI for exclude some osteochondral fragment and some of the occult fracture of the neck femur.
Okay, Dr. Abhisit, what do you think?
I'm not sure about it had a fracture of femoral head or not, because the pain film and the CT scan is not show me about the quality of the femoral head.
Atit, please.
The recent film, I think the patient has collapse of the femoral head with some reason, but before the CT scan, I think the patient may have a fracture of the head via acetabulum. But the CT show, to me, I cannot, because it's quite quick, I cannot see the fracture clearly. So I think the patient absolutely have the dislocation of the reduction and have collapse of the femoral head with some reason, maybe a vascular necrosis.
Chavarat, please.
I agree with Dr. Atit.
Yeah.
It is definitely a posterior wall fracture, and then there's something happened that made the head collapse.
Chavarat, please.
Fracture supero-posterior at the acetabulum. Maybe fracture of the femoral head, but now it developed a vascular necrosis of the femoral head. And leg length discrepancy on the left side too.
Okay. Please, Professor Tenenit.
I think it's a fracture dislocation with the last piece of a posterior wall.
Okay.
Usually, a vascular necrosis is occur a little bit late.
Yes.
Just 7 weeks.
Yes, 7 weeks. That is the important information.
Yeah, if the head deformed quite a little bit early, it should form fracture or something.
Okay. So I think we have the conclusion of the diagnosis is that we have the posterior wall fracture and then somewhat deformed head, but from what cause we don't discuss that. And so what is your plan to manage in this case? I would like to start with someone who talk not too much a lot. Dr. Chavarat, please. What do you think you're gonna? How do you think? Chavarat, please.
Okay. In this case, because the head is already collapsed, so definitely we need, and the acetabulum is not in a good shape. Definitely we need the total hepatoplasty. Well, for the acetabulum, you may have for the femur side is normal, pretty straightforward. But for the acetabulum, you may have a problem about the bone loss, especially on the posterior wall, which is quite an important part. But normally, if I see the bone like this, I don't think there is much of a problem. You can remove the fragment over there if it's still not union.
Which fragment?
Posterior wall fragment. If you can't, don't worry, just use the femoral head, the rest of the femoral head to use as a bone graft and put it in on the posterior side and put in the normal primary cup, cementless cup.
Atit, do you do the same way that Chavanon?
In my opinion, the patient 61, if the patient needs only one surgery, I think hip replacement. One stage fix the fracture of the acetabular wall and just do I prefer cementless to hip replacement.
So anybody sitting here not doing arthroplasty, only go reduction and fixation. Okay, please.
I think it's just 7 weeks, and I want to know about the to evaluation of the quality of the femoral head, and I think I need to fixation at the posterior wall and some technique to fixation to femoral head, and I need to evaluation. And do you have a CT scan in the 3 dimension for the evaluation of the femoral head?
Yes. Do you have a 3D recon? No,
I don't.
It is okay.
I don't have. I have only the CT scan after the close reduction and the anesthesia.
Okay, so that is very interesting technique. But I want to ask you that what approach will you do when you want to fix both head and posterior and not compromise a lot of blood supply to the femoral head? If you will do the open reduction and fixation.
I choose the posterior approach, and I point to the posterior wall, and I think it's being to the list to dislocation.
And do you plan to dislocate or subluxate the head if the head has a defect or something?
Sometimes I choose the dislocation of the femoral head for the OIF with pinless screw or something, and I think it's a chance to keep the joy, and in the future I will go to the total hip replacement.
Any panel has a different opinion. If we want to go into reduction and fixation, anybody like to comment on this method? What will you do? อาจารย์ทนายนิด noนิด
Me? For fixation, posterior approach. For total hip arthroplasty, posterior approach.
For fixation first.
For fixation,
If you plan to do
posterior approach.
What is your technique?
Technique?
Yes. What is your tip in this case? I think we're gonna find this kind of case very common.
Yes. For me, if the patient has a definite femoral head fracture and posterior wall fracture, posterior approach usually may need to dislocate. I think in the most situation, but in some situation, if the fracture is just like split out, to just attach and in situ fixation is possible, and just reattach the posterior wall. But most of the case, the fracture is tend to if you good and need to have a good reduction for the femoral head is maybe likely to dislocate the hip.
Thilawit?
For the case like this, if we can define the femoral head fracture and not 7 weeks, that 1 or 2 weeks, I think I will approach by the posterior and try to dislocation of the femoral head, fix the femoral head fracture with the screw, and reduce, then fix the posterior wall of the acetabulum.
I know. But the challenge thing is that how can we dislocate the head without compromising the blood supply by going posterior? Any tip? Gasisin, do you have any tip for this?
I think everybody would go to the posterior approach.
Okay, yes.
And then maybe if the wall of the acetabulum is has some space that we can fix inside too. So we lucky. We don't need to dislocate the hip. And then just only cut the capsule and then fix it inside too. And then after that, we fix the posterior column of the acetabulum later.
If it is not,
If it is not, I still need to dislocate.
yes. And how you dislocate it? How you preserve the blood supply?
I think we cut the capsule not like the T shape that we use normally, and then just only linear cut.
Yes. Okay. So there are different techniques to not jeopardize or not compromise the blood supply. That is maybe the thing that we should discuss later, or maybe let the trauma guy discuss it. So I think a lot of our panel will go to the total hip reconstruction. How can you reconstruct the hip in this case? Sivadon, please. Do you go in anterolateral?
In this case, I go to posterolateral approach because the problem of this problem, the fracture at the superior-posterior of acetabulum.
What do you do with the fragment?
If the fragment is still intact or large piece of bone, I put the screw to fix it.
Screw?
Yes.
Okay.
And then put the acetabular cup in the normal fashion. If the fragment is maybe it arises of a small piece of bone, if you use the femoral head to reconstruction at the posterior superior part, and I use it depends on the piece of part. Either a small fragment, I use the screw. Either large fragment, maybe the plate and screw. And use the simulate acetabular component, simulate femoral component, metal and highly costly polyethylene.
Professor Thananit, your suggestion in this case, what you approach, what you will do, direct anterior beginning incision or?
We routinely do anterolateral.
Right this case too?
Normally.
Oh.
Very not too difficult.
Not too difficult.
But I think the fragment should be fixed. If the fragment for the long time, it resolved it. And posterior is very thin. So if you want to reconstruction, head is better.
Head is better.
Is it better because anterolateral.
Oh, good.
You have to come to see that.
Okay. I will do.
Not too difficult. And I think if you use the femoral head, have a large area to purchase the screw. It better than you tie to a very thin posterior wall back. It's not good support.
So you will do the screw.
Yes.
And paste the cup. Anterolaterally.
Okay,
thank you. Who will do anterolateral? The panel. Okay. Any suggestion, Dr. Thana?
For myself, I'm concerned about the fixation first because anterolateral can be done, but the key of my practice, I try to keep the capsule and blood supply to the piece of the bone first. And we pension bone graft, and then we will put the screw. Like Dr. Thananit said, if we don't trust about the fixation, we may apply such a buttress paste to prevent the superior dome.
Buttress paste from anterolateral. Okay. You are better than me. Okay. Please, Chavarat, please proceed with the case.
In this case, we choose to do in one stage both the fixation and total hip arthroplasty. Okay, we use the lateral decubitus position and cochlear Langenbeck approach. And this for the intraoperability for my approach, and the femoral head defect can see, and the large posterior wall fragment can see, and a refixation of the posterior wall with the.
So you take the bone out to take the picture.
For the best picture for
Okay.
conference.
Okay.
We refixation with the reconstruction plate, and after the fixation, the fragment stable enough for reaming the acetabulum. Okay, and this is the post radiograph.
Okay.
Operative radiograph.
Okay, who I asked last question for the panel. Who will use plate fixation? Who will definitely use plate fixation for that fragment? No one? So everybody use screw. Only screw. Okay, thank you very much. Okay, thank you, Dr. Chavarat.